Case number 3. Let's say you have a young person who comes into the emergency department complaining of some palpitations, and for good reason. What you'll notice here is a very rapid rhythm. This is a narrow, regular tachycardia, and just quick recap, whenever you see a narrow, regular tachycardia, remember that there's really just 3 main causes. Sinus tachycardia is going to be your most common cause, and then you've got atrial flutter with 2-to-1 conduction, and then third, SVT. And there's a handful of different types of SVT, but in emergency medicine, we typically just lump all of them into this one category and call it SVT because they tend to have fairly similar prognoses and treatment. How do you tell the difference between these 3 entities? Well, you need to ask yourself a simple question. What is the atrium doing? If sinus tachycardia is present, you'll see 1 P with every QRS. So you'll see PQRS, 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 and so on. With atrial flutter, the atrium is beating twice for every ventricular beat. So you'll see PPQRS, PPQRS, PPQRS. And with SVT, oftentimes you don't see P waves because they're buried inside the QRS, or sometimes you'll see what's referred to as little retrograde P waves, where just after the QRS you get a little blip, and that's referred to as a little retrograde P wave. So what's the atrium doing here? Well, if you look carefully, you really don't see PQRS, 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 so we can get rid of sinus tach. You really don't see 2 P waves for every QRS, so we'll get rid of this, and that leaves one option, SVT. And then looking more carefully, you do actually see the very classic retrograde P wave, which typically is most obvious in the inferior leads. V1 often will show it very nicely as well. And so this is an SVT. More specifically, the type of SVT that is notorious for producing these little retrograde P waves is referred to as an AV nodal reentry tachycardia, also known simply as just AVNRT. So what do we need to know about AVNRT? Well, again, this is a very common type of SVT. Rates can approach 140 to 180, even up in the low 200s sometimes. And typically, with this type of SVT, you will get retrograde P waves, especially in the inferior leads, just the way we saw. There are a few key sex-specific teaching points with regards to AVNRT. This is definitely more common in women, 2 to 3 times more likely to occur in women than in men. And it's the most common type of SVT that we'll see in young women. Unfortunately, there's a gender bias that occurs with this diagnosis in that women oftentimes have a more delayed diagnosis, and they also, in a more delayed fashion compared to men, get referred to the definitive therapy, which is ablation, when they're having recurrent episodes. So that's something that we need to be aware of. Your question is the following. In AVNRT, which sex is less likely to be referred for an ablation?